Without much further delay, I am going to start the presentation. So coming to my first topic, the first topic we are going to discuss is about the anemias. So first of all, we are going to talk about the difference between severe anemia versus acute blood loss. Now in both these conditions, the hemoglobin level in all the patient is very low. Obviously, as we all know, so severe anemia, it may be due to the chronic disease, and acute blood loss is mainly due to the blood loss or hemorrhage. So what is the difference between? So for that we have to very much give importance to the history and the clinical examination. So first of all, if you talk about the history in case of severe anemia or anemia of chronic disease, the patient will usually present with long standing fatigue, pallor, exertional dyspnea. जैसे कि पेशेंट कुछ कदम चलेगा and he will always complain that डॉक्टर साहब जैसे ही चल रहे हैं थोड़ा सा थकान होना शुरू हो गई है. So that is exertional dyspnea, and most of the time the patient will have nutritional deficiency anemia, some chronic disease, or if the female patient is there, then she will complain of menorrhagia. Either the period will be prolonged, or if the duration is normal but amount of blood loss will be more. So that is also one of the causes. Then chronic GI bleed can be another important cause of anemia of the severe disease. So that is the main important things in the history. So thorough history and the clinical examination is very, very important. Now the second category is the acute blood loss. So here the most important history we can get is the recent trauma. The surgery may be possible, some patient have undergone some surgery. Then hematemesis is very important history. Melena, dark colored or black colored stools, these are also very important. If the patient is, patient may present with PPH, postpartum bleed, and some accident history patient may give history of recent trauma. Now onset of the symptoms usually in the severe anemia, the onset is usually gradual or insidious. In the acute blood loss, the sudden and within minutes. Now again we will talk about these HB and MCV and peripheral smear in the further slides. But again if you talk about the clinical signs, usually the anemia of severe anemia with chronic disease usually present with pallor, glossitis, the painful red inflamed tongue, koilonychia, the changes in the nails like spoon shaped nails, chronic changes, and the patient is usually stable with stable vitals unless there is a very severe loss. Now in the acute blood loss category, the patient usually present with shock, tachycardia, hypotension, cold extremities, and sometimes the patient may present with collapse. So these history and the clinical importance is very, very important. Now if we talk about the classification of the anemia by the category, then number one is the blood loss. Again the blood loss can be acute or chronic depending on the etiology, and the trauma, GI bleed, and all these things are mainly the category of the blood loss. Now if the decreased, the second category is the production is only decreased. Now that is the second most common, that nutritional marrow, bone marrow failure can be there, nutritional anemia very common in our country like India, and anemia of chronic disease. The examples of these conditions are iron deficiency anemia, vitamin B12 deficiency, aplastic anemia, and CKD. Now the third category is the RBC's production is okay, but the RBC is destroyed in the circulation only, and that the most classical example is the hemolytic anemias. An example is like sickle cell anemia, thalassemia, then G6PD deficiency, autoimmune hemolytic anemias, paroxysmal nocturnal hematuria, and malaria. Now if you talk about the RBC size, depending on the RBC size we can classify the anemias by microcytic, normocytic, and macrocytic. So on the CBC report we can see that if the MCV of the patient is less than 80 femtoliters, then which falls under the microcytic category, and this is the most common scenario that we see in the OPD, because the most common cases in our OPDs are mainly iron deficiency anemia. Then the second is the maybe some anemia of chronic disease, and the picture in the peripheral smear will be hypochromic and microcytic. Now the second category is the normocytic category, and here the MCV is between 80 to 100 femtoliters, and the most classical example is anemia of acute blood loss and hemolysis, and sometimes the patient may present with aplastic anemia. Here the RBC size is normal. Now the third category is the macrocytic anemia, where the MCV is more than 100, and the most common cause in our country India is vitamin B12 and folate deficiency. The second common is the alcoholic liver disease and hypothyroidism, and here on the peripheral smear we will see the macrocytes and the hypersegmented neutrophils will be present. Now if you talk about the reticulocyte count, this is also a very, very important topic, because depending on the reticulocyte we can know the function of the bone marrow. If the bone marrow is proper functioning of the knot, because reticulocyte count provides a picture of the bone marrow of the patient. So number one category is the increased, So conditions in which the reticulocyte count is increased, the first is the hemolytic anemias, very common because autoimmune hemolytic anemia or hereditary spherocytosis, the hemolytic anemias, the reticulocyte count will be increased. Then acute blood loss, whenever an acute episode of blood loss occurs, after 3 to 5 days, the patient's reticulocyte count again increase because the bone marrow is basically compensating and RBC production is increased. Now iron and B12 therapy for correction. So if the patient is having iron deficiency or vitamin B12 deficiency, usually the reticulocyte count is decreased because the bone marrow is devoid of the reservoirs. So if there is no nutrition to the bone marrow, in the iron and vitamin B12 deficiency, it is reduced. But when the therapy is started for correction, so after few days, mainly after 1 week, the reticulocyte count starts increasing. So that is also a very important test we can understand for that. Then the second condition in which the reticulocyte can be normal or inappropriately low, that is the iron deficiency anemia or anemia of chronic disease. Now the third very important condition in which the reticulocyte count is decreased, and here the most important cause is aplastic anemia. Usually the patient may be either in the early 20s or early usually 10 to 14 years or 15 years and or 60 plus. Now the second most common cause is the acute leukemias, where the bone marrow is not responding and the bone marrow is full of blast. So basically the reticulocyte count is decreased. Then myelodysplastic syndromes, then bone marrow infiltration disorders like lymphomas, metastasis, fibrosis and CKD, because erythropoietin level is low. As we know that the kidneys produce erythropoietin hormone, and if the kidney is only not properly functioning, the erythropoietin hormone is also hampered. So due to that, erythropoietin hormone will not act upon the bone marrow and the reticulocyte count will decrease. So basically, just to summarize these things, if you are seeing a patient of severe anemia with low reticulocyte count, you should think of bone marrow infiltration with leukemia, aplastic anemia or myelodysplasia. And if the patient is having severe anemia with high reticulocyte count, then we should think of peripheral destruction or acute blood loss like hemolysis or bleeding disorders. Patient is acute blood loss. So now again a very important point here, that if the patient is having very low hemoglobin with stable vitals and the cause of the anemia is unknown, the unknown or unexplained anemia, then we should always ask the patient for the color of the stool. That is very important, because if the color of the stool, patient is complaining that I am having dark color stools or black tarry stools, then that means the patient is having GI bleed. So we should always check for occult blood in stool. And if the occult blood in stool comes positive, then the next step is we have to go for endoscopy and colonoscopy. And most likely we are going to find out some GI ulcer or gastric polyp or some malignancy in the colon or in the stomach. So this is also very important. Now, so again, if the patient is having with acute blood loss, the patient looks sicker than the HB suggests. So shock with normal hemoglobin, and in case of severe anemia with chronic disease, the patient will look better even though the hemoglobin is low, because the patient over the weeks and months starts adapting to that low HB level. So that is the most important distinguishing feature between two, and this is the most common anemias are the most common cases that we are facing day to day in our emergency. Now next very important table here, the pancytopenia, because almost daily 3 or 4 patients are coming in our emergency with pancytopenia. So most common cause, again when we talk about the pancytopenia, the number 1 cause in our country India is the megaloblastic anemia, and the most common deficiency is vitamin B12 and folate deficiency, because in our country usually the population is especially villages, and there is the deficiency of vitamin B12 is very common. So the most common cause in India is megaloblastic anemia. Then we should think of aplastic anemia, but aplastic anemia will usually present with pancytopenia. Then acute leukemias, but acute leukemias will present with pancytopenia, but blast will always be present in the bone marrow. So if the bone marrow shows more than 25% blast and the peripheral smear shows more than 20% blast, then we think of acute leukemia. Then another condition is the sepsis and DIC. This also present with pancytopenia. Then the malaria and the dengue. Nowadays these 2 diseases also increasing. So now life-threatening infectious causes should be ruled out first, because leukemia, malaria, dengue and sepsis, these should be ruled out immediately if the patient is presenting with pancytopenia. And we should also rule out between the leukemia and aplastic anemia, and the peripheral smear examination must be done, but the patient should be stabilized first. and always check for bleeding, infection and hemodynamic instability. So, first line of investigation in pancytopenia, we have to do the CBC with smear review, rapid malaria and dengue test, blood cultures, reticulocyte count and the basic LFT, RFT and coagulation profile. Now, another very important point here, the difference between the leukocytosis, leukomoid reaction, leukemia and leukopenias. Now, again we can see that in reactive leukocytosis, the WBC count is usually between 11,000 to 30,000. It will be increased, but the most common cause again is the bacterial infection, stress and steroids. The patient distinguishing feature here, neutrophilia can be seen with left shift, and in the leukomoid reaction the count is much more, it is in the range of 30,000 to 1 lakh. But this is completely benign condition, that is very important, and the peripheral smear will not show any blast. And this condition can be seen in severe infections and hemolysis and sometimes in the carcinoma. But if you talk about the leukemias, the count is again more than 50,000 to up to 2 lakhs. But this is a urgent hematological condition, and the most important distinguishing feature with leukomoid reaction is that we can see the blast or the atypical cells in the bone marrow. So, based on the blast and the atypical cells, we differentiate between the leukemia and the leukomoid reaction. And talking about the leukopenia, if the condition is less than 4,000, then we call it leukopenia, but if it is less than 1,000, it is severe leukopenia. So, most common cause is the sepsis, viral infections, aplastic anemia, the patient undergoing chemotherapy and the leukemias like AML and ALL. And the risk of overwhelming infection is very high in this leukopenia. So, in general, just to summarize these things, leukemias, it can be present with very high WBC count, it can present with normal WBC count, and it can also present with leukopenia. So, all the three situations are possible in the acute leukemia. The secondly, the classical clinical picture of the acute leukemia is the patient with leukemia will present with anemia and along with thrombocytosis and the leukopenia or leukocytosis. Both are conditions are possible. Sometimes the patient presents with 1 lakh WBC count, and sometimes the WBC count is completely normal. Is just 3,000 or 4,000 WBC count is there. So, both the situations are possible. Now, coming to a case scenario that I encountered 2 months ago in our OPD only. This patient was a middle-aged 43-year male. He presented with persistent cough and redness over the face. These were the only two complaints. He was having redness over the face and persistent cough. No improvement was seen with oral injectables. Now, history of persistent leukocytosis. Again, hemoglobin was completely normal, 15.7. Total leukocyte count was increased, 28,000. Platelet count was completely normal, but the differential count, the only important finding was eosinophils 80%. So, this was the only important finding that we had, that eosinophil was 80%. Rest hemoglobin was normal, the platelet count was normal, and but whenever the patient presented, he was having elevated WBC count, sometimes 30,000, sometimes 40,000. So, absolute eosinophil count came out 12,800, so it was marked eosinophilia. So, whenever this eosinophilia, we see the eosinophilia, number one we think about parasitic infestations. So, first differential diagnosis we thought was parasitic infestations. The second was allergic conditions like atopic disorders like asthma, allergic rhinitis and eczema. Then we can think of drug-induced eosinophilia. Then apart from that, the fourth differential diagnosis was connective tissue or autoimmune disorders like eosinophilic granulomatous with polyangiitis, because this also affects the lung and the patient was having cough. So, this was also in the differential diagnosis. And lastly, we can think of hypereosinophilic syndrome or chronic eosinophilic leukemia, that is very rare. So, these tests were advised, but in our hospital the patient was referred because we did not have much tests that can be done here. So, the patient went to the SGPGI Lucknow, and there the workup summary of this case is as follows. The stool examination was negative, and the filaria serology and the strongyloid serology was also negative. Serum IgE level were normal, so that rules out the allergic causes. Now, ANA and ANCA, that is anti-nuclear cytoplasmic antibody, these two were also negative. So, these two were also negative, so connective tissue disorders like SLE and autoimmune conditions are also ruled out here. So, chest X-ray was done, mild infiltrates were present, but these mild infiltrates are not very diagnostic because they can be seen in any conditions. Even if the patient is having mild cough or some viral infection, the mild infiltrates can be present. Now, bone marrow examination was performed there. The patient only showed marked eosinophilic hyperplasia with no blast. That is also very important, no blast was seen. So, molecular cytogenetics was performed on this patient, and this came positive for FIP1L1 PGD-FRA fusion. Now, this is a very important genetic rearrangement. This is basically platelet derived growth factor. Now, this is a very important molecular cytogenetic test for chronic eosinophilic leukemia, and the patient, the final diagnosis of this patient came out to be chronic eosinophilic leukemia, which was confirmed by this rearrangement. So, this was a very rare case, and this gene is located on chromosome number 4, and due to rearrangement this FIP1L1 joins with PGDFRA, that is platelet derived growth factor gene, and as a result the tyrosine kinase activity of this gene increases. Now, tyrosine kinase activity, as we all know, is also illustrated in CML. So, the same drug that is very much helpful in CML like imatinib was also helpful in this condition also. Like this patient was dramatically responding to imatinib because it is a tyrosine kinase inhibitor. So, that is why these tests are very important, and sometimes the follow-up patient have to be done. Now, coming to the next topic, that is thrombocytopenia. Now, the platelet count, if it is less than 1,50,000, we call this thrombocytopenia. Now, number one cause is the decreased production. The bone marrow is only not producing the enough platelets. So, the cause can be aplastic anemia, it can be bone marrow failure. The important cause can be megaloblastic anemia, bone marrow infiltration by the leukemias and lymphomas, myelodysplastic syndrome. So, these are the causes when the bone marrow itself is not producing enough platelets. Now, the second important cause is the increased destruction. Now, the bone marrow is completely normal, it is producing the platelets, but the platelets are destroyed in the circulation. Now, the cause could be immune or non-immune. Now, immune mediated cause is basically ITP, immune thrombocytopenic purpura, could be SLE or drug induced like quinine and heparin. On non-immune cause, very important is DIC, especially in the pregnant females, DIC is very common, then thrombotic thrombocytopenic purpura, then hemolytic uremic syndrome and sepsis. So, all these conditions, they can cause increased destruction of the platelets. Then if the patient is having splenomegaly, obviously if the patient is having splenomegaly, then all the platelets are sequestered in the spleen. So, the patient will in turn have decreased platelet count. And finally, the dilution due to the massive transfusion by the platelets, massive transfusion by the RBCs, then the platelet count can be very low. So, the key differentiating patterns, we have to always remember the ITP, the platelet count is very low, usually less than 30,000. Similarly, in the aplastic anemia, but in the megaloblastic anemia, leukemias and DICs, the platelet count can be low, maybe 70,000, maybe 80,000, but it will not be very much low. So, if the patient is having isolated thrombocytopenia, we should think of ITP. If the patient is having pancytopenia, we should think of bone marrow failure like aplastic anemia. And if the patient is having hemolysis with cystocytes, then think of DIC and thrombocytopenic purpura and hemolytic uremic syndrome. And if the patient is having splenomegaly, the hypersplenism may be the cause of decreased platelet count. And of course, the patient is presenting with fever, then we should always think of dengue or malaria. Now, coming to the very important topic, that is the cardiac biomarkers. So, we have to differentiate between these three tests, troponin I versus troponin T versus CKMB. Now, very important topic for the AMOs, because almost daily we are encountering this patient and these tests have to be routinely ordered. So, time to rise for the troponin T is usually 3 to 4 hours, troponin I, and troponin T rises from within 4 to 6 hours, and CKMB within 3 to 6 hours. Now, duration in the blood, this is very important. Troponin I remains elevated for 5 to 10 days, troponin T remain elevated for 7 to 14 days, and CKMB remains elevated for only 2 to 3 days. And that is the reason why this is used for detecting reinfarction, because after 3 days the CKMB level will be normalized. And if the patient is having acute myocardial infarction on the 5th day or the 6th day, so we can again order CKMB and reinfarction can be again diagnosed. So, due to because it normalizes early, we can diagnose for reinfarction of the patient. Now, sensitivity, always troponin I is very sensitive and specific, because it is very specific with the cardiac muscle, but CKMB, it is also secreted by the skeletal muscle, that is why it is not very much specific. So, the key point is troponin I, these are the gold standard, rise earlier, more specific and remain elongated for the longer period of time. On the other hand, CKMB is still useful for detecting the reinfarction, and these markers should be interpreted with ECG and the clinical findings. Now, let us talk about the anti-proBNP. We have started performing in our labs anti-proBNP recently. So, what it is basically it is an inactive form of proBNP. The proBNP is basically brain natriuretic peptide. It is the active form. Now, when this hormone is secreted, whenever there will be the ventricle muscles, when they were contracting and there is ventricle stretch and wall stress beyond they can handle. And what is the most common condition when the ventricle stretch happens? That is the heart failure, obviously. So, it is a marker of heart failure, and it is used to diagnose heart failure severity also. Now, again, clinical use in the diagnosis of the heart failure, in the severity and the prognosis of the heart failure, and for monitoring the therapy, it is also very important. Now, if you talk about the cutoffs, if the patient is having acute heart failure, like the patient is presenting with acute dyspnea, the cutoff is less than 300 picogram per ml. If the patient is having less than 300 value, then most unlikely this is not heart failure. Now, if the patient is, if you want to rule in heart failure, if you want to diagnose it, then we have got three situations. If the patient is less than 50 years, the value should be more than 450. If the patient is between 50 to 75 years, the value should be more than 900. And if the patient is more than 75 years, value should be more than 1800. So, this is the diagnostic cutoffs for acute condition. If the patient is presenting with acute dyspnea. And if the levels are more than 10,000, that means the patient is having very severe heart failure. Similarly, if you talk about the chronic heart failure, the condition can be divided into age less than 75 and age less than more than 75. So, less than 75, the cutoff value is less than 125, and age more than 75 years, the cutoff value is 450. Now, a few words about the electrolyte disbalances. So, if you talk about the electrolyte imbalances, the most common is the sodium imbalance and the potassium imbalances. So, sodium imbalances basically hyponatremia, we can the most common cause is SIAD. Apart from that, overall most common is the diuretics, because the patient is elderly and he is having hypertension and other comorbidities like diabetes. So, hyponatremia can occur at any age, but epidemiologically the most commonly affected group is the elderly population, as we all know, because the elderly population, they eat less, they sleep less and they drink less. So, and they have these decreased renal concentrating ability, more frequent use of thiazide, because most of the time they are hypertensive, they are already taking antihypertensive medications also, and they are also taking antidepressants, SSRIs. So, that is why the most commonly affected age group is elderly. And if you talk about the hypernatremia more than 145, then most common cause is dehydration and water loss. The patient is usually present with fever, diarrhea and burns. If you talk about the potassium imbalances, the condition less than 3.5 millimoles, hypokalemia, patient will present with muscle weakness, cramps and constipation, but if the condition is severe, he may present with arrhythmias. And always you can find the U waves on the ECG. The most common cause again is the diuretics, the antihypertensives. The patient may also come with diarrhea and vomiting. If you talk about the hyperkalemia, again potassium level more than 5 millimoles per liter, muscle weakness and paresthesia, and in the severe conditions cardiac arrhythmias can be present with peak T waves and wide QRS complex. The most common cause again is the renal failure with acute kidney disease or the chronic kidney disease, and potassium sparing drugs like spironolactone are also very common. Now again let us discuss about the CRP and ESR and Procalcitonin. Now again these two, ESR and CRP, these two are very non-specific tests, they can be raised in any conditions. But ESR again in our country India, whenever we are suspecting TB, tuberculosis, most of the time this is raised, but it is very non-specific, and in anemias also it can be raised. Now CRP, it is better than ESR because time to rise is much less than ESR. But the best test is Procalcitonin, the value is less than 0.05 nanograms per ml. Time to rise, it rises very early at 2 to 4 hours and peaks within 12 to 24 hours. So, it is very highly specific for bacterial infection. So, if we talk about the Procalcitonin, it helps to distinguish between the bacterial and the viral infection, and it guides the antibiotic initiation and discontinuation. So, this is much sensitive and much specific test. Now, coming to the CSF interpretation, another very important topic. So, if you talk about the normal CSF, we can know it is clear and colorless. The cells 0 to 5 per high power field, only occasional lymphocytes are seen in the normal CSF. And if you talk about the protein, 15 to 45 mg per dl is the normal range. But coming to the bacterial meningitis, on the appearance the CSF will be turbid and sometimes purulent depending on the severity. The cell count is very high, can be up to 10,000 per high power field. And the most important cell that helps to distinguish and clinch the diagnosis is the neutrophils. Similarly, in the viral meningitis and the tubercular meningitis, the cell type is lymphocytes. Again, the classical the picture that we can see is the cobweb on the CSF. But due to the use of the antibiotics and all this, we don't see the clear picture because patient already has taken so much antibiotics and then they present. That's why we are not seeing this cobweb. So most important thing that we can help to diagnose is the neutrophils in the bacterial meningitis and lymphocytes in the viral meningitis. So this is the most important thing, and the protein will be elevated in all the conditions. In the bacterial also, mild elevation in the viral, but high in the tubercular. So if you talk about the causes, then most common cause in India of the bacterial meningitis in the neonates less than 1 month is the Klebsiella pneumoniae and E. coli. And if we talk about the infants more than 1 year up to 5 years, the leading cause is the Streptococcus pneumoniae. And in adolescents and the young adult, Neisseria meningitis and Streptococcus pneumoniae, these are the 2 most common causes. In the elderly population and adults, the most common cause is Streptococcus pneumoniae. If you talk about the viral meningitis in India, the most common cause is the enterovirus. Apart from that, arbovirus causing the Japanese encephalitis is also very common in UP, Bihar, Assam, Andhra Pradesh and Tamil Nadu. And in regions where the vaccination is not properly given, the mumps can also cause meningitis. So sometimes atypical or malignant cells can also be seen in the CSF, which helps to diagnose the brain malignancies like medulloblastoma and ependymoma, because these are the tumors that can shed the cells into the CSF. And on the cytology, we can diagnose these tests. Apart from that, secondary CNS involvement can also be seen like in the breast cancer, lung cancer, melanoma and lymphoma. If you talk about the leukemias, then acute lymphoblastic leukemia, acute myeloid leukemia and non-Hodgkin lymphoma, these are the malignancies that can be diagnosed on the CSF. So another case scenario, a boy of 14-year-old, he was having a progressive weakness of both legs for 4 days. Now, and also he was having a history of diarrhea 2 weeks ago, which was self-limiting and no antibiotic was needed. Now, important thing is that he was not having any fever, no headache was present and seizures, this history was not present. On examination, this is very important, flaccid weakness was present with ascending pattern and the patient was having arthralgia in the knees and ankles. So, depending on the clinical history, we can think of the picture where we are leading to. Now, routine blood investigations were performed, like CBC was normal, electrolytes and thyroid function and RFT completely normal. Nerve conduction studies were performed and reduced conduction velocities were seen. Now, CSF analysis here very important, the protein was increased, cells were completely normal, only 2 cells were seen. Now, this condition is called as albuminocytologic dissociation, and this albuminocytologic dissociation is classically seen in Guillain-Barré syndrome. This is a very classic case of GB syndrome and the most common cause is the Campylobacter enteritis. So, this is the post-infectious final diagnosis this was made. So, important point here is that the CSF showing albuminocytologic dissociation, the protein will be increased, but the cell count in the CSF will be completely normal, and this is the very important point. So, the take home message we can see here, if your patient is presenting with acute fever, altered sensorium, neck stiffness and the CSF is showing neutrophils with high protein, we should think of bacterial meningitis. If the patient is having fever, headache, photophobia with lymphocytes and protein mildly raised, we should think of viral meningitis. If the patient is having subacute fever, not very high grade fever, with headache and cranial nerve palsies, again very important finding, cranial nerve palsies with lymphocytic picture, high protein and ADA is also raised. Now, this ADA is also raised, so we should always think of tubercular meningitis because the ADA is raised. Now, again if the patient is having subacute fever with lymphocytic picture and on India ink we can see the microorganism, then we should think of fungal meningitis. And finally, if the patient is presenting with classical acute ascending symmetrical weakness with areflexia and albuminocytologic dissociation, we should think of Guillain-Barré syndrome. Now, coming to the pleural effusion, again very important topic in the OPD and also in the emergencies. So, pleural effusion causes which can be classified into 2, transudative and exudative. So, most commonly if you talk about the transudative cause, congestive heart failure is the most common cause worldwide. Apart from that, cirrhosis is again very important. Then in our country India, if you talk about the exudative effusions, we should think of tuberculosis, the most common cause in India. Almost in our OPD what we are facing is the tubercular cause. 80 to 90% of the patient are tuberculous only. Then sometimes malignancies can also be there. So, just to summarize, if the patient is having transudate, we should think of systemic disease like congestive heart failure, cirrhosis and nephrotic syndrome. And if the patient is having exudate, we should think of local pathology like TB, infection or malignancy. So, this is the Lights criteria. Again, it is a very important criteria to diagnose whether the transudate or exudate, to confirm whether the pleural effusion is of transudate type or exudate type. Here the class, if any one of the criteria is met, we will call it exudate. Now, pleural fluid protein to the serum ratio should be more than 0.5, pleural fluid LDH to serum LDH should be more than 0.6, and the LDH, pleural fluid LDH should be more than 2/3 of the upper normal level of the serum. So, if any of the criteria is met, it is almost always exudative, and if none of the criteria is met, we call it transudative. So, again the difference we have already mentioned, the protein will be important here. Just we can remember, in exudate everything will be in excess. Exudate means excess. So, protein will be excess more than 3, LDH will be also very high, and the cell count will also be very high, either the neutrophils or the lymphocyte depending on the etiology. On the other hand, if you talk about the transudate, the protein will be less than 3 gram per dl, LDH will be low, and these cells will also be very low. So, now again coming to the again a case scenario, the patient 52-year-old male, progressive breathlessness for 2 weeks, dry cough, low grade fever, chest X-ray showing large pleural effusion, USG thorax free flowing effusion with no septation, straw color, fluid was aspirated. So, appearance straw color, protein was again raised, LDH is also raised, that is also above the Lights criteria we can see, glucose is on the lower side, cytology is showing lymphocyte rich or lymphocytic rich effusion. So, coming to the ADA, this is a very important test in our country India, especially in the our part. ADA, if it is raised, we should always think of tuberculosis, and luckily usually the AFB smear is positive, but it came out to be positive. So, the diagnosis of tuberculosis was confirmed. Now, here again another case, this case 60-year-old male, female with non-smoker, progressive breathlessness. Here also if you see, the protein is raised, LDH is also increased. Now, here we can see on the pleural effusion large atypical clusters. These are large atypical clusters with prominent nuclei and 3D ball like clusters. So, this is the case of malignant pleural effusion. Now, coming to the ADA, this is mainly produced by the activated T lymphocytes and macrophages. Now, especially in our country like India, it is increased. If the ADA is more than 40, we should strongly think of tubercular pleural effusion, and if it is more than 70, very high probability. So, coming to the ascites, ascites we can again think of common causes of ascites in our country India. The most common cause worldwide is cirrhosis, and in our country alcoholic liver disease is the most common cause. And non-portal causes can be malignancies, apart from that tubercular peritonitis and the heart failure. Now, first step we have to see the gross ascitic interpretation, like clear usually seen in the cirrhosis, turbid in the infections, bloody in the malignancy in the traumas, and milky in the chylous ascites. This is the chart I have given just for the quick reference. Now, again very important is the SAG ratio, serum albumin ascitic gradient. If we subtract the serum albumin and the ascitic fluid, we can get the value, and if it is more than 1.1, we should think of portal hypertension, and if it is less than 1.1, we should think of tuberculosis and malignancy. Again I have given this chart for quick reference. And again cell, if the polymorpho are seen, then we should think of spontaneous bacterial peritonitis and lymphocyte predominance, TB or malignancy. Biochemistry already we have discussed in the previous chart. Protein is less than 2.5, then cirrhosis or nephrotic syndrome, more than 2.5, malignancy and tuberculosis. Now, coming to a case scenario, this is a 37-year-old female, progressive abdominal distension with vague abdominal pain, loss of appetite for 2 months. Now, examination, ascites was present, no jaundice, no significant lymphadenopathy. Now, protein was 5.65, which was raised, and it coming to the exudative category. Sugar was low, total leukocyte count came out to be 5,000, which is also raised. Now, ADA was borderline, not strongly suggestive of tuberculosis. So, differential leukocyte count, nothing significant, lymphocyte was raised, but important point here, we got the atypical cells were seen. Now, whenever atypical cells are seen in the peripheral smear, we have to confirm whether these are reactive mesothelial cells or whether these are malignant cells, because atypical cells have to be cleared out. So, we apply special stains, like we applied JAMSA and PAP stains to confirm the malignancy. So, these are the cells we can see here. These are large 3D groups of cells with atypical cells, high NC ratio with pleomorphic nuclei. So, this came out to be malignant ascites. This was the case of metastatic adenocarcinoma, and in a young female with this picture, we should always think of the primary site as ovary, because it's young patient. So, ovarian carcinoma very common. So the next step we have to think of tumor markers like CA125, CA and CA19. Now coming to the tumor markers, very quickly we will go through the tumor markers. The most first of all we will discuss about the alpha fetoprotein. These are mainly raised in the hepatocellular carcinoma and yolk sac tumor, but falsely they can be raised in chronic hepatitis and pregnancy. CEA, it is normal range is less than 3 nanogram per ml in non-smokers, and in smokers it is less than 5. Now again CA is mainly raised in colorectal and pancreatic cancers. Now CA125, very important test. It is mainly used to for the diagnosis of epithelial ovarian carcinomas, and usually done in the females. But again, very important point have to be noted that it can be raised in endometriosis, it can be raised in menstruation, TB and pregnancy. So these also very important. Then CA19-9, it is raised in pancreatic adenocarcinoma and cholangiocarcinoma. Now PSA, again very commonly prescribed, mainly in the prostate cancers. So coming to our last topic, dengue. So the etiology, we all know, dengue virus, flavivirus or RNA virus. 4 serotypes are mainly responsible, 1, 2, 3 and 4. Now the vector is Aedes aegypti, that is the primary, it breathes from the fresh water, it is a day biter. Transmission is mainly from the bite of the infected mosquito. Now clinical features, we can see the incubation period is 4 to 10 days after the mosquito bite. Now this is the classical dengue rash we can see, and usually it is a maculopapular rash, islands of white in the sea of red, that is what we mentioned in the textbook. Now sudden high grade fever 2 to 7 days, severe headache, retroorbital pain, myalgia, arthralgia is also known as the break bone pain. Now dengue hemorrhagic fever, the plasma leakage, due to the plasma leakage the patient may also present with pleural effusion or ascites. Thrombocytopenia is usually present with 1 lakh, less than 1 lakh platelet. Now dengue shock syndrome, this can also occur if the patient is having severe plasmatic and dengue shock syndrome present with shock and multiple organ failures. Now coming to this very interesting diagram, we can see here the febrile, we have divided the days of illness from 1 to 10. Now during the febrile period, we can see during the first 3 days the temperature of the patient is raised, usually 38 degree, 39 degree and up to 40 degree can be there. Now this day 4 and day 5, these are very critical because the temperature here is down, but the potential cause of shock and bleeding occurred during this critical period, that is the day 4 and day 5. And the thrombocytopenia also occurs in the day 4 and day 5. Otherwise, after the 6th day the recovery starts. Now investigation, we can see the most important test is the NS1 antigen, usually positive from day 1 to day 7. Early diagnosis, it is best for the early diagnosis, and if it is positive, it confirms the diagnosis of acute dengue, even before the antibodies. Now IgM, again it is positive for day 5 and declines over 2 to 3 months. And IgA, if you talk about the IgA, appears after day 7, it indicates past infection and it persists for decade or lifelong. Once the patient becomes positive, it can stay for lifelong. Now again this interpretation, if the NS1 is positive and IgM and IgG both are negative, then we should think of very early acute dengue infection, that the day 1 and 5 is going on. If the NS1 is positive and IgM is positive and IgG is negative, then we should think of acute dengue, the day, usually the day is between day 5 and day 7. Now if NS1 is negative, IgM is positive and IgE is negative, we should think of recent infection. If both NS1 and IgM is negative and only IgG is positive, we should think of past infection or the person is immune. Now if IgM and Ig both are positive and NS1 is negative, then we should think of secondary dengue infection, and if all the 3 are positive, we should think of acute secondary infection. Then this is again diagram. We can see here during the first 4 days NS1 antigen is positive. On the nearly about the 5th day IgM starts getting positive, and on the 7th day IgG starts getting positive, and IgM after 14 days starts declining and becomes normal, but IgG remains elevated throughout the lifetime. So as discussed, day 1 to 5 NS1 antigen is the best test. RT-PCR can also be done. For the day 5 and 10 IgM is positive, that is the next best investigation. And regarding the CBC and NS antigen together, they give the more than 90% sensitivity. So always correlate with the CBC because the platelet will be decreased and hematocrit will be increased, and negative test does not rule out dengue if done early, because less than 3 days if you are doing the test, it may come negative. So the treatment, only supportive therapy is there, no specific antiviral therapy is there. The patient should be rested, oral fluid should be given, paracetamol for the fever and aspirin. Monitor vitals, urine output very important, bleeding signs and symptoms, and platelet count and hematocrit. And management, basically if the patient is having mild problem, then oral rehydration. If dengue with the warning signs like abdominal pain, mucosal bleed, persistent vomiting, then crystallites and shock syndrome, then rapid IV fluids. And platelet transfusion, if the patient is having less than 10,000 platelet count, even without bleeding, the platelet transfusion should be given. And if the patient is having active bleeding, even though he is having the platelet count around 20,000, then platelet transfusion should be given. So finally, the take home message, Aedes is the vector, day biter, it bites during the day. Thrombocytopenia, leukopenia and hematocrit will be increased. NS1 for the early test, for the day 5 IgM, treatment is fluids, platelets and severe thrombocytopenia, avoid NSAIDs. And these are my references. I have taken these from the Harrison's, from the Nelson test book, and Robbins WHO guidelines for the dengue monitoring and pleural effusion, and these are the